Welcome to ILD RA QD Clinics. I'm Dr. Bryant England from the University of Nebraska in Omaha, Nebraska. Today's case is entitled, Be Careful What You Look For. Now, our patient today is a 57-year-old female with a history of right knee pain and a diagnosis of osteoarthritis. But she started developing hip, hand, ankle, and foot pain over the last few months. This is accompanied by about 1 to 2 hours of morning stiffness. She's a former smoker of 1 pack per day for 15 years, but quit 8 years ago. Today in clinic, she has a BMI of 43 kilograms per meter squared. She has a little fullness in her MCPs. Her lungs are clear to auscultation. Her serologies return with a CCP greater than 300. Her rheumatoid factor is 440, and her CRP is 2.7 milligrams per deciliter. Radiographs of her hands show possible MCP erosions, and the patient started on methotrexate, which is escalated up to 20 milligrams by mouth weekly. Within a few months, the patient has really complete resolution of her articular symptoms. There's no synovitis detected on exam, and she's functioning well in life and work. She's doing so well, she decides that she's going to participate in a research study where she undergoes a chest CT and pulmonary function test. The chest CT shows mild ground glass attenuation in the bilateral lung bases on both supine and prone imaging. And pulmonary function tests show an FVC of 77% predicted and an FEV1 of 82% predicted. As part of that visit, she has detailed assessment of her respiratory symptoms, and she does admit to a bit of shortness of breath and dyspnea of exertion over the past few weeks. Now, based on these findings, this case actually gets reviewed in a multidisciplinary discussion between rheumatology and pulmonology. Ultimately, it's felt that these findings are nonspecific, with the potential for these to be a drug reaction, early interstitial lung disease, or of another cause. Because of this uncertainty, the methotrexate is discontinued and azathioprine is started in its place. Over the coming months, the patient's articular disease remains very well controlled. She notices a little subjective improvement in her symptoms. She's able to do a little more physically at work without trouble. And PFTs over 1 year later remain stable with her baseline assessment. In terms of imaging over time, unfortunately, she develops COVID-19 pneumonia, and those changes obscure any of the initial changes that were seen. So this case really highlights the point of what do we do when interstitial lung abnormalities are detected in a patient with rheumatoid arthritis. Now, when we see findings of interstitial lung abnormalities, such as reticulation, ground glass changes, one of the things that comes up right away is this RA interstitial lung disease? But other things on the differential include things like drug-induced pneumonitis, particularly if a patient is on a medicine that we think of this frequently, such as methotrexate. And if that's the case, then the question comes up, well, what do you do with their current medications? Do you stop methotrexate in somebody who has incidentally detected interstitial lung abnormalities? Some important things to consider in this situation is that not all interstitial lung abnormalities or restrictive PFT findings are evidence of RA interstitial lung disease. So we just talked about that differential, including other things such as drug-induced pneumonitis. But also infections or post-infectious reticulation can also appear similarly. People who have fluid overload, perhaps related to heart failure, may have some of these similar changes. And then on PFTs, we can have other causes of restrictive lung disease, such as obesity, other chest wall diseases. Another important point is that when we incidentally detect these interstitial lung abnormalities or ILA, that doesn't necessarily mean that treatment changes are required. In some situations, after a detailed assessment of this patient, we might be able to keep them on their current therapies and just monitor them closely over time. But there are some things that the identification of an ILA does require in a patient with RA. And that is, number one, we need to thoroughly assess this patient. We need to ask about respiratory symptoms such as shortness of breath, cough, dyspnea of exertion. We need to obtain pulmonary function tests to understand their pulmonary physiology. These should be complete PFTs with spirometry, lung volume, and diffusion capacity. If available, it's always a great idea to have a multidisciplinary discussion with the pulmonologist and with the radiologist to discuss the potential etiologies of these findings. After doing these assessments, we don't want to stop and never assess them again, but rather these assessments should be part of their ongoing care. so we can understand the trajectory of their imaging findings, their pulmonary physiology, and their symptoms. We need to target the risk factors that can predispose these abnormalities to worsen or impact their survival. So things like if they're a cigarette smoker, we need to talk to them about smoking cessation. If they're exposed to other inhaled exposures, we need to mitigate those. We need to talk to them about optimizing physical activity levels. Then finally, when we detect an ILA, we also need to make sure that there weren't other findings on that CT scan we need to act on. So other incidental findings of particular interest are lung nodules, because patients with ILA are at higher risk of developing lung cancer. So those are the things that we absolutely need to do to really understand and monitor the disease over time. The things we may need to do require making treatment changes. But again, remember that not all ILAs are definitely RA-ILD. Keep your differential open. So thanks for joining me to discuss this case.